Hello, how are you? Today I want to talk to you a little about pacemakers. I kept thinking about the previous video. I thought it was a good idea to tell you a little about pacemaker. So let's get to it. There are many people today that are pacemakers users. People who have a pacemaker or cardiac device. These devices, in addition to controlling the frequency and rhythm of the heartbeat, keep a record of the rhythm and frequencies. Then later, when the patient comes for control, when the clinician or cardiologist take the patient in for control, we see the rhythms and frequencies that the patient had and also the action of the pacemaker in the face of these variations. Arrhythmias can be detected and recorded by pacemakers. Atrial fibrillation, for example, which is an arrhythmia of clinical importance and one of the most common arrhythmias. And I think is the most common of those that are clinically important. Can be detected then by cardiac devices. When this is the case, it is called subclinical atrial fibrillation or atrial high rate episodes, AHRE. It is a common finding in patients with cardiac devices, pacemaker, defibrillators, resynchronizers, and insertable holters, and it is associated with a higher risk of a stroke. Several studies have shown that the episodes of subclinical atrial fibrillation are associated with an increased risk of thromboembolic events. Actually, what has happened recently is that a meta-analysis that combined the results of the NOAA-AFNET atrial fibrillation network and Artesia. Artesia is apixaban for the reduction of thromboembolism in patients with device-detected subclinical atrial fibrillation. To evaluate the efficacy and safety of anticoagulation in device-detected subclinical atrial fibrillation, the researchers included in the analysis just over 6,500 subjects who were administered apixaban or edoxaban for the management of subclinical atrial fibrillation detected by devices, or also called for high-frequency atrial episodes. The authors identified that the use of anticoagulation reduced the risk of a cerebrovascular event by up to 32%. Likewise, anticoagulation reduced the risk of cardiovascular death, acute myocardial infarction, pulmonary thromboembolism, or ischemic stroke from any cause by up to 15%. However, a 62% increase in the risk of major bleeding was observed. Thus, the authors conclude that although the data from these trials constitute a high level of evidence supporting the potential effectiveness of anticoagulation in these cases for the reduction of various cardiovascular outcomes, safety must be personalized, essentially due to the risk of major bleeding. When registering subclinical atrial fibrillation, atrial high rate episodes, what is recommended is to first do an 12 leads electrocardiogram to see the rhythm and frequency there, and then this decision are made in this regard considering all the patient's risk factors and contraindications. You have to see the patient as the individual that he or she is. It should be noted that in the case of a patient in whom subclinical atrial fibrillation is detected, even atrial fibrillation with symptoms, who is not candidate for treatment with NOAC or treatment with anticoagulants, one must document in the patient's medical history what has happened and the decision that is made. For example, atrial fibrillation of this or that frequency is detected, but the patient has this or that contraindication for NOAC. He cannot receive this prophylactic treatment. Thus, it is clear one evaluates the patient's particular cases and choose not to give him the treatment because the potential risk exceeds the possible benefits. Do you know how a pacemaker works? These devices do the following. They exchange information with the heart. They send impulses from the generator to the heart so that it contracts with a minimum frequency established by the doctor who programs the pacemaker. This is the stimulation function. And then they send information from the heart to the generator so that the latter detects, feels if the heart beats on its own to inhibit itself, not stimulate in that case, and not send stimuli, since if the heart beats, it is not necessary for the generator to work. Pacemaker thus saving battery and extending the average life of the system. This is the sensing function. There are three main types of pacemakers. Single chamber pacemakers affect only the atrium or ventricle. There are pacemakers in AAI and BBI mode. Dual chamber pacemakers affect the atrium and ventricle, normally right. There are pacemakers in VDD and DDD mode. The acronym AAI, VVI, etc. constitute universal codes to clearly designate the type of pacemaker. The first letter defines the stimulate cardiac chamber, A atrium, V ventricle. The second, the sensitive chamber, and the third, the mechanism of action, I inhibition, T triggered, D both. The three-chamber pacemaker, CRT, this acronym stands for Cardiac Resynchronization Therapy, is a pacemaker with electrodes in both ventricles, which is why it is called biventricular, and it is three-chamber because it has another electrode in the right atrium. It is indicated in cases that need a pacemaker and have left ventricular dysfunction. Its mission is to achieve better and more coordinated contraction of the heart, as close as possible to the natural contraction of a well-functioning heart. It is the only type of pacemaker that can improve EF, ejection fraction. In the normal contraction of the heart, there is a synchrony between the atrium and the ventricle there, where first the atrium contracts and then the ventricle. An interventricular synchrony, as some of you might know, the right ventricle contracts a little before the left. And finally, I want to mention the ICD. It can have one, two, or three electrodes. That is, it can have only one electrode in the right atrium or two electrodes in the right atrium and right ventricle, or three electrodes, right atrium, right ventricle, and left ventricle. It has the action of a defibrillator and pacemaker action. Then the different types of pacemakers are chosen according to the age and weight of the person who will have the pacemaker. For example, in a patient in less than 10 kilos who, or 33 pounds who needs a pacemaker, it is not advisable to implant the pacemaker intravenously because the cables will not enter through the subclavian vein, which in theory will be very small in this patient. And even if we manage to insert the cable, there is a risk of thrombosis and occlusion of the vein, complicating implants in the future. A patient with atrioventricular block might receive several types of pacemaker throughout their life. For example, a 3-kilo child or maybe 6.6 pounds child in the first month of life receive a single ventricular epicardial lead connected to a single chamber BBI generator epicardial pacemaker. At the time of the first generator replacement, at around 4 or 5 years old and with about 10 to 15 kilos, about 33 pounds. If the electrodes is good, it could be used and only the generator replaced, given that small children tolerate the lack of synchronization well. If it is bad, it is cancelled and a new intravenous ventricular electrode is placed to the subclavian vein at the same time as a new generator. We achieve the desired frequency, but still no atrioventricular synchrony. This new pacemaker will wear out around 10 to 12 years of age of the child. It is time to induce a new intravenous cable to the atrium and replace the battery with a dual chamber DDD type. Finally, synchronous stimulation is achieved. Since the atrial cable will detect the atrial beat, and the pacemaker will then send an electrical impulse to the ventricles, to the ventricular electrode. Well, I mention this because children also have pacemaker, although it is much less common. In general, it is adult patients who have pacemakers, but so that they are not forgotten. And also because I wanted to raise to those differences when deciding which pacemaker to use and how to choose the way to implant them. The thing to consider. After pacemaker implantation, periodic technical and clinical checks are required to ensure adequate performance of the device and adapt the stimulation to the patient's changing conditions. In general, the follow-up of a patient with a pacemaker will be as follows. Early surveillance includes the initial phase after implantation, suggesting an evaluation prior to discharge and 4 to 6 weeks after hospital discharge. It allows evaluating the condition of the generator bag and the adequate optimization of equipment parameters, especially the output due to the lowering of the stimulation threshold after implantation. The maintenance period is the second phase and includes monitoring after the first evaluation, suggesting an annual periodicity. The determinants of periodicity should be considered in each evaluation, and if they exist, the need for intensified monitoring should be raised. Lastly, heightened monitoring is monitoring more intensely as the device approaches the end of battery life, 75% capacity consumption, or any other indication of battery depletion, as well as the presence of unexpected change in measurements, change in lead impedance or threshold. Considering the periodicity of evaluation of 3 to 6 months, as well as the planning and indications of hospitalization. Occasionally, some external electromagnetic sources, such as electrocautery during surgery, can cause interference. This can confuse the device, which interprets that there is intrinsic activity and response by inhibiting cardiac stimulation with possible hemodynamic consequences and or discomfort for the patient. Also, in cases of therapeutic external stimulation, I am specifically talking about electroconvulsive therapy, ECT, to treat cases of severe depression, or electroconversion, electrical cardioconversion, to treat, for example, atrial fibrillation, in those occasions when it is known that the patient is going to be exposed to electric shock. A magnet is placed over the pacemaker. The magnet produces a configuration change in the pacemaker to asynchronous mode. The sensing function is inhibited so that the device generates a stimuli with a fixed frequency temporarily. I mean, for as long as the magnet is in place. It should be taken into account that this response varies depending on the brand of the device and the condition of the battery. In Medtronic type pacemakers, when the magnet is placed, it remains asynchronous at 85 beats per minute. If the device is in ERI, the response of the magnet will not be 85 bytes per minute, but 65 bytes per minute. The Sanjus model's response to the magnet is asynchronous at 100 bytes per minute. If it is in ERI, it will be 85 bytes per minute. Boston Scientific device has the same answer as the previous one. The Biotronic type is German, is not Biotronic, but doesn't matter. When the magnet is placed on it, it's asynchronous at 90 bytes per minute. And if it is in ERI, the response will be 80 bytes per minute. The pacemaker states are as follows: BOL, beginning of life; ERI, elective replacement indicator; ERP, elective replacement period; EOS, end of service; EOL, end of life. The expected duration of these states varies for each made and model. The expected duration of these states varies for each make and model, and that information is read in the manuals of each device. But the ERI status lasts between 3 to 6 months. And here I leave you this. I would like to read your comments if you have any experience with this, if you can add any important information as a doctor, nurse, or physiotherapist, or as a patient. And well, thank you for your attention and be very well.